Welcome to this recruitment and retention event for Cumbria's adult social care sector. Today is about practical resources designed to help providers, particularly smaller organisations, improve the way they recruit and retain staff, with emphasis on planning an approach to recruitment and retention that is effective and affordable. Before we start today's first recruitment and retention session, let's take a quick look at some of the trends and challenges within our sector. Health and social care think tank, the King's Fund, have undertaken a review of some of the most significant trends and drivers that they believe will affect health and social care services over the next 20 years. Patients Like Me and other websites continue to connect and empower the general public. Mounting financial pressures threaten viability and sustainability of many health and social care providers. General election. Expect health and social care to be a hot topic for debate. Expect the majority of the population to access the web through mobile devices. Routine use of electronic health record in most health and social care settings expected. Predict 2.9 million people will have 3 or more chronic conditions, 1 million more than 2008, with an additional cost of £5 billion. Microchips improve delivery of and compliance with medications. Depression, due to be the major cause of disability globally. Potential shortfall of between 40,000 and 100,000 qualified nurses. Expect routine use of teleconsultations and remote monitoring. Regenerative medicine likely to have created new treatments for heart and bone disease. Genetic profiling to predict risk of disease could be routine. Adult social care workforce would need to grow by 1 million if current service patterns maintained. 4 million people expected to have diabetes, nearly 30% more than today. 1 million people expected to have dementia, with estimated care costs of nearly £35 billion. Robots could be routinely used at home and in care settings. Rising global temperatures could be starting to have significant economic and environmental impact. Around 4 million people likely to need help with daily living. Arthritis expected to increase by 100% to 17 million people. Ethnic populations likely to make up 15% of UK population. 8 million more people living in England than in 2012. Life expectancy at birth expected to be around 87 years for women, 83 years for men. 4.8 million people aged over 65 and 1.4 million people aged over 85 expected to be living on their own. State pension age rises to 67. Up to 46% men and 40% women could be obese. Beyond the next 5 years, the predicted rise in the number of people with disease and disabilities are sobering. The need to derive value from every pound of health and social care spend is never likely to have been greater than it will be over the next 20 years. Innovation cannot be just about doing more things for more people. New technologies will need to be exploited to the full to drive up productivity, or the NHS and social care services could struggle as they try to meet this growing demand with no equivalent growth in resources. A need for creative and innovative workforce planning has never been more critical. It is time to think differently about health and social care, but don't take our word for it. Listen to some of the comments from the King's Fund Time to Think Differently programme.
Money and resources and keeping it at a good standard because of probably the lack of money that they may have.
You see that there are far more elderly people. You know that people who had life-threatening or limiting conditions are living much longer. In fact, I'm one myself.
We are living longer, so there are going to be more elderly people and less people working. But I do think we should make people work till they're a lot older. You know, the pension age should be later, because it also has been proven to show that less people will get dementia if their mind is still active. But that depends on the workplace that they need to then encourage to employ more older people so that we've got more people working, and basically keeping people healthier.
Someone brought up that type 2 diabetes is based on lifestyle as opposed to something that you're born with. And the idea was that basically if we could get people to start paying for that service themselves, it would kind of give them an incentive to fix their lifestyle. However, I think what the opposing side was saying was that people aren't educated enough due to the lifestyle they've lived, where they've been, to actually know that I shouldn't be doing this or I shouldn't be doing that. So it was kind of, I think at that point with the educational topic, I kind of joined them both. And I was like, what we're saying is that we need education, but we need it quickly.
I think the biggest challenge is funding, and I think really it's down to what kind of government we have and what they prioritise. I think there's always going to be big public opinion about things, but really when it comes into implementing those changes, it's going to come down to the government and how they prioritise and what they decide to spend things on.
The requirement to take services that were designed to meet different needs at a different time and to change them so that they're more accurately attuned to meeting the needs of today's group of service users. It's the requirement, I think, as Mike Farrer of the NHS Confederation has put it, to design a care system with medical support, a medical adjunct, rather than imagining the system will continue to be as it used to be, a system designed to deliver an episode of care to somebody who's normally healthy. That's not where the majority demands placed on the system now come from. If we focus on the majority of the services provided by the system, these are already and will increasingly be people who have a requirement for care and support and help, engaging with them. It's not something you do for them, it's not a form of charity, it's in enabling them to get the most out of their lives on a long-term basis. It's a long-term relationship. It's not a transaction. And if you interpret the requirement that way, working with them to enable them to get the most out of their lives, it needs to be much more community-based. It needs to use modern technology, modern communications technology, obviously the clinical technology, but modern communications technology, much more effectively than it does now. And rather than waiting for something acute to happen, an acute need to arise, and then intervening and probably taking them into hospital to manage that acute episode, what we should be doing is enabling them to prevent that episode arising in the first place, and as I say, to get the most out of their life, rather than becoming increasingly dependent on a system that will provide emergency intervention, but is very poor at avoiding the need for the intervention arising. The expectations already are changing. One of the things that I think we should recognise is that although once you're in an acute hospital, you probably get high quality care, actually that's a minority of the requirement in the system now. The majority of the system already need these kind of joined-up services provided much closer to home, and that's a need that the system is bad at delivering. And one of the problems we have, actually, I think, looking forward, is that we're encouraging people and whole communities to believe that the system will become better at delivering those joined-up services to people in their own home that families already know are not being delivered well today. There's a quality issue, there's a financial issue everybody's aware about, but there's actually a quality issue. The core demands being placed on the system are not being well met today. And if we don't design it to meet those needs more effectively, it will go on getting worse at delivering its core purpose. In my mind, the prime responsibility lies on the people who crudely sign the checks to the people who deliver the services. We can just go on ticking boxes and sending checks to people who deliver services as they've always been delivered. And if we do that, A, we'll run out of money, and B, people will be hurt. Large numbers of people will be hurt badly. The responsibility rests, therefore, in my mind, on local authorities through the health and wellbeing boards engaging with the local NHS commissioners to use resources to insist that resources are used by the system in a way that reflects the needs of today's and tomorrow's patients, rather than simply paying for a way of delivering care that we've inherited from the past.
I hope what the healthcare system will look like is a service which is much closer to people's homes, where we support particularly growing numbers of older people to live independently in their homes with their carers, with their relatives. We make use of new technologies like telehealth and telecare to facilitate that. We place less reliance on care homes, nursing homes and hospitals. We use them for what they're intended, which is the provision of specialist care for people with acute needs. But above all, what I hope we will see is a much more joined up, integrated system with GPs working closely with hospital specialists, health and social care working more closely together, physical and mental health services much more integrated, because the changing demographics and the shifting disease burden needs care that's integrated, not care that is fragmented. The big challenge is moving from where we are to where we need to be to address these shifting patterns of need and demand in the community. That requires much more innovation in the delivery of health and social care. Innovation, in our view, at scale and at pace, changing the old models where they're no longer fit for purpose, and being willing to accept new models of care wherever they may come from, whether it's the third sector, voluntary sector organisations, or indeed from within the NHS itself. That requires two things. First of all, we must support NHS staff and social care staff to do things differently. They must be able to get off the treadmill, to have the time and the slack to think about how they can improve health and care, not just carrying on doing the day job. If we ask them to do that, this is not going to happen. And secondly, we must be more open-minded as to where those innovations will come from. I think a lot will happen within our existing providers of hospital and other care, but we know that there are some exciting opportunities from outside, from the private sector, from the independent sector, from companies who may not have been involved in healthcare but have innovative solutions to offer. And the health and care system needs to be much more receptive to those innovations in care in future.
It's something that, as a mental health trust, we struggle with constantly every day. We believe passionately in. The ways in which we do it, for example, are the absolute commitment to the recovery model, which is around the whole quality of life of all of our service users and indeed their carers, who also need to be involved in the issue. We involve them very strongly in governors' roles. About 50% of our governors are service users. So increasingly there are ways in which we can and do engage our service users in their care and in the decisions around their care. And it's only through doing that, particularly in mental health, that people are empowered to take control over their own futures. I think it's not a question of whether it's possible. I think it has to be possible. We need only look at the demographics and the ageing population to know and understand that if we don't have a fully integrated service, we will never meet the needs of that part of our population. It's a tough thing to do. It's a tall order, but it has to be done, and we have to get better at doing it.
We're going to really have to address that rising levels of expectations. We shouldn't disparage it, we should respond to it. And again, empowering staff to really focus on those public expectations will allow the real transformations in patient care that will be needed alongside the financial challenges that we face.
I think it's clear looking to the future that the models of care haven't kept pace with changes either in the demands of patients or indeed with wider changes in society such as technology. Looking across changing demographics makes very clear that the numbers of very old people are going to increase as a proportion of the population. And as we know, they're also the heavy users of health and social care. And it's really critical that we rethink how we deliver care to meet their needs. At the moment, we have a system that's been built around curing and treating, about dealing with people who have urgent one-off need for care. In the future, and even today, an increasing number of patients are frail and elderly with multiple chronic conditions, and they need a different type of ongoing care and support that will take them right through until they die. I think it's really hard to say how the health and social care system should look in 15, even 20 years' time. I don't have a crystal ball in which there is any certainty. But I think there are things that we know do need to change, and where we really need to look hard and rethink how health and social care are delivered. I think that means thinking about where care is delivered. I think much more care needs to be available to people in their home or near their home. I think we need to make much greater use of information technology. We all carry our smartphones. How can we harness the information revolution that we have all experienced for changing how we interact with health and social care? And I think we have to look really hard at the workforce. The numbers show that we can't go on as we are in terms of both the ageing profile of the workforce in health and social care, but also whether the costs of the intensity of professional care that we provide. So it may mean patients and families doing more for themselves, and it may mean new and different types of workers. I think these are all areas where health and social care are going to change really radically, and we definitely need to be thinking differently.
We know that care is getting more and more specialised and therefore more and more fragmented. That's how patients see it. We know that that most people actually do want to do whatever they can to help themselves. And so actually helping them to see themselves as kind of co-producers or co-managers of their care is what professionals, what clinicians ought to be trying to do. Confidence. Actually believing that their views, their experiences are important. We can't go on delivering services in the kind of fragmented way that they're currently delivered. So patients, service users don't divide themselves up into chunks that are dealt with by different professionals. So we've got to become much more integrated, coordinated, holistic in the approach. They're becoming more critical, which is a good thing, more sceptical, really, more aware that not all healthcare is beneficial. Some of it, that there are harms as well as benefits to most medical interventions, that there's a great deal of uncertainty about what's best to be done for a particular problem. I hope they'll become more choosy, more selective, and I hope that they will be helped to make informed decisions about their care. There definitely is a demand among many for much greater involvement in the decisions that affect them.
We've heard from some of the contributors to the King's Fund Time to Think Differently programme, a piece of work designed to stimulate debate about the changes needed in health and social care to meet the challenges of the future and the opportunities. But did you know that about 15 million people in England have a long-term condition? By 2025, the number of people with at least one long-term condition will rise to 18 million. Around 30% of all people with a long-term physical condition in England also have a mental health problem, most commonly depression or anxiety. Mental health problems exacerbate physical illness. Inequalities in mental health remain stark. The gap in life expectancy between those with a severe and enduring mental health problem and those without is between 10 and 15 years on average. Over the next 20 years, the number of people in England aged between 65 and 84 will grow by over a third, and those over 85 will more than double. In 1901, life expectancy in England was 45 years for men and 49 years for women. In 2012, men and women could expect to live for just over 79 years and 83 years respectively. By 2032, this is expected to extend by a further 4 years for both sexes. By 2018, it is estimated that there will be 7 million older people in the UK who cannot walk up a flight of stairs without resting. It is estimated that there are more than 570,000 people with dementia in England, and over the next 30 years, that is expected to double to 1.4 million. 11.3 million people are predicted to be living on their own in England by 2033, 40% of all households. In 1961, only 12% of households were single-person households. In the future, the increase in numbers of frail older people and more patients with long-term conditions will mean we need to rethink where and how care is delivered. In 2001, there were 12,800 district nurses in England. In 2011, this had decreased by 36% to 8,200. Digital communication offers new ways to interact with patients. 4 out of 5 people in the UK can currently access the internet at home, and everyone in the UK will have access to the internet by 2025. The current digital divide between young and old, rich and poor, will be a thing of the past by 2032. The ageing population will lead to a rapid increase in demand for adult social care. Between 2010 and 2025, the adult social care workforce would need to increase by at least 1 million jobs. There are around 3 million volunteers currently working in the health and social care system in England. The information contained within this presentation suggests that without further action, the health and social care workforce will not be able to meet growing demand effectively. A need for creative and innovative workforce and service planning has never been more critical. We can start today.